and welcome to the channel. I'm Dr. Mohsen Raj. I'm a DM cardiology student at AIMS Delhi. And in this video, we'll resume our ECG series. And this is video number 5, and we will be discussing on ventricular hypertrophy. So technically, it is about recognizing on an ECG strip whether right ventricular hypertrophy or left ventricular hypertrophy is present. So what this slide depicts is you have the normal situation on the top row, and then you have the situation of left ventricular hypertrophy in the middle row, and then we have the situation of right ventricular hypertrophy in the bottom row. And it's very easy. It is almost a no-brainer. Just a simple pattern that you have to remember, and you will be able to interpret it. So as you probably remember from the previous video lectures, so this is how a normal ventricular depolarization occurs. So in the start, we have depolarization of the interventricular septum, and the septum depolarizes from its left side to its right side, from the left to the right, which is the reason why the right precordial lead, which is V1, records a small positive deflection, an R wave. And which is why the left-sided lead, that is lead V6, records this initial negative deflection. That's the Q wave, also called septal Q wave, because it was produced by septal depolarization. And then after this initial septal depolarization, the rest of the ventricle depolarizes. And we know that it occurs from the endocardium to the epicardium direction, right? From endocardium to epicardium, it depolarizes the whole width, the bulk of the ventricular muscle. And we know that normally the left ventricle has more muscle than the right ventricle, which is why the electrical forces of left ventricle dominate the electrical forces of the right ventricle, which is why the single arrow that is shown in this picture, it is pointed towards left. It is pointed towards what is known as the average or mean QRS axis. So it's directed towards left because left-sided ventricle, the left ventricle has more muscle. More muscle means more electrical force. More electrical force means that the vector, the mean vector, will be pointing towards the left. That's the mean QRS vector or the cardiac axis, right? So because it's pointing to the left, you can see that the left-sided lead V6 records a predominant positive deflection. So this is how a normal QRS should look in lead V6. And this is how a normal QRS looks in lead V1. So this is normal situation. Now let's understand a situation called left ventricular hypertrophy. This video is not about causes of left ventricular hypertrophy. So if you remember, common things like systemic hypertension produce left ventricular hypertrophy, or some sort of pressure overload like aortic stenosis produces left ventricular hypertrophy. So that's for some of this video. But here, as you appreciate that the left ventricular wall has become more thick, more muscle, more electricity, which means that the left-sided forces will be more predominant, which is what is shown here. So this R wave in the left-sided lead, that is V6, remember V6, V5, lead 1, lead AVL, they're left-sided leads. So here the QRS deflection is very tall, okay? And on the opposite side, in the right-sided lead, that's V1, the S wave, remember, this part was due to left ventricular depolarization, right? So this S wave in the lead V1 becomes deep. This R in the lead V6 becomes very tall. So a deep S in V1, a very tall R wave in lead V6. This is what is left ventricular hypertrophy. Simple. And now look at the right ventricular hypertrophy situation. So in certain situations, maybe in situations like pulmonary hypertension or pulmonic stenosis or some other situation which is responsible for right ventricular hypertrophy, it's now the right ventricle whose muscle is thick. So which means it's the electrical activity or electrical forces of right ventricle which will dominate over that of the left ventricle. So which is why the arrow in this picture, which is mean QRS vector, is directed towards right, towards the right of the midline. So as a result, your right-sided leads, that's lead V1, instead of recording a predominant negative wave, look at this, it's a predominant negative in the normal situation, but in the situation of RVH, it's going to record a predominant positive or an exclusively positive wave. Okay, so in this situation, there's a tall R and then an S. Or you simply have an R wave. There's no Q, there is no S. Or you have a QR complex, a small q and then a tall R. But in any of these situations, the R is the dominant wave in lead V1. And then take a look at the left-sided lead, that's lead V6. You have a deep S wave. So a simple rule, a tall R in V1, a deep S in V6 is what is right ventricular hypertrophy. Simple pattern recognition. I repeat, lead V1 and lead V6. This is what you have to look. Lead V1 showing a deep S wave. Lead V6 showing a tall R wave is left ventricular hypertrophy. Lead V1 showing a tall R wave. Lead V6 showing a deep S wave is right ventricular hypertrophy. Simple, straightforward stuff. Now let's together read this ECG. Obviously, you know this is a sinus rhythm, okay? But I'm not going to go into those details of this ECG, but specifically, look at the lead V1 and look at the lead V6. You see deep S waves in lead V1 and tall R waves in lead V6. So this ECG has evidence of left ventricular hypertrophy. And there's an important thing that you might be supposed to know in an exam, in your final year exam, or even in your NEET, PG, or ICT, is this definition, the Sokolo-Leon voltage criteria. This is the criteria. There are many other criteria, but this is the one that is most commonly utilized. Sokolo-Leon, remember the name as well. And it is the S wave in lead V1. Remember, I told you it's deep. And the R wave in lead V5, I've told you that it's tall. So instead of V6, that this criteria uses V5, which is also a left-sided lead. So the S in V1 plus R in V5 more than 3.5 millivolts, right, is what is left ventricular hypertrophy. Another part of this definition is when in the lead AVL, you have a very tall complex. So the R wave in the lead AVL is more than 1.1 millivolts. So remember this thing forever. S in V1 plus R in V5 more than 3.5 millivolts. This is left ventricular hypertrophy. So now, what about this ECG? Okay, so here, as you see, there's a predominant R in lead V1. There's a deep S in lead V6. So yes, this ECG has evidence of right ventricular hypertrophy, right? Okay. Now what else? You see these ST segment depressions and T wave inversions. This is sometimes what is called as RV strain pattern or secondary repolarization abnormalities. You may see such secondary repolarization abnormalities of ST depression, T wave inversion in V1, maybe V2 or V3 in case of RVH, or you might see these abnormalities in leads V5, V6, V4 in case of LVH. These are known as secondary repolarization abnormalities or strain pattern. There's so many different criteria for right ventricular hypertrophy, but the only one that I want you to know is this R by S more than 1 in lead V1. I've told you that in a normal situation, if you remember, in lead V1, R is smaller than the S. You have a smaller positive R, but a deep negative S. So R by S will be negative in a normal situation. In a situation of RVH, your R by S is more than 1. This is the definition of right ventricular hypertrophy. Now, before we close this video, I will discuss this ECG with you, revising what we have learned today and something that we learned in the previous video lecture. So yes, this is a normal sinus rhythm because there's a P followed by Q followed by T. So P, QRS, T, this pattern, every QRS is preceded by P and every P is followed by QRS. This is what we know as normal sinus rhythm. If you take a look at the rate, it's roughly around 120 beats per minute. I've told you in a previous video how to calculate heart rate. If you check the axis, this is right axis deviation. I would encourage you to watch other videos on this channel on how we tell the axis on an ECG. In fact, I've told you how you can exactly determine what degree, not just right axis and left axis, the exact degree to which the mean cardiac axis points, okay? And then if you take a look at the lead V1, you appreciate that there are tall R waves. If you take a look at lead V6, you appreciate there are deep S waves. If you take a look at lead V1, the R bias is more than 1. So this ECG has evidence of right ventricular hypertrophy. But there are some other things on this ECG. If you take a look at P waves are also abnormal. You have these tall peaked P waves in lead V2. In lead 2, this is pointer of right atrial enlargement. You have these, if you take a look at lead V1, you normally have biphasic P waves. I've told you in the previous video lecture, okay? So if you take a look at the terminal negative deflection, it's too deep and prominent. So there's evidence of left atrial abnormality as well. So this ECG is a sinus rhythm with a heart rate of roughly 120 beats per minute, has a right axis deviation, has right atrial enlargement, left atrial enlargement, and right ventricular hypertrophy. So this ECG was from a patient with mitral stenosis, and it's expected in such patients to have left atrial abnormality, have pulmonary hypertension, and as a consequence of that, have right ventricular hypertrophy and right atrial abnormality. So many findings in one ECG. We will meet in the next video, which will be based on atrioventricular conduction. See you in the next video. Thank you.